We're not personally thinking about our own mortality. So therefore, we're not talking about it with the people that we love, and definitely not planning ahead for it often enough. And unfortunately, how that plays out on the medical side of things is far too often people are getting care that they don't maybe want, and they definitely don't understand. And it's not in line, with their goals and values.
Hello, everyone, and welcome to the Health Technology Podcast. My name is Christine Minotto, and I'm the director of UCSF Rosenman Institute at the University of California, San Francisco. Our guest today is Dr. Shoshana Ungerleider, who works as an internist practicing hospital medicine at California Pacific Medical Center here in San Francisco. She's also a recipient of 2 Academy Award nominations for 2 documentary movies, Extremis and Endgame. You can find both of these movies on Netflix. Dr. Ungerleider also organized the 2018 March for Our Lives in San Francisco against gun violence. In addition, she's also a philanthropist and activist. Although she doesn't work in palliative care, she is a palliative care activist who thinks we should all talk about and plan for what happens at the end of our life. Today we're going to talk about her journey and her work, and I hope you really enjoy our conversation and inspired by her passion. And if you like what you hear today, please subscribe to our podcast on iTunes. Well, thank you, Shoshana, for joining me today. I remember the last time we met, that was a while back ago, a couple years ago. You were just nominated for your first Oscar, and I thought what you're doing is really interesting. But before we start, maybe we can go over with a little bit about your background and history, why you chose this field, which is in the palliative care. How did you end up where you are today? What's the beginning story?
Ooh, the beginning story. It's a great question. I thought in college that I wanted to be a marine biologist. So I studied, a bunch of science, and spent my last few months of college out on the Oregon coast, studying at a marine lab where I was conducting all sorts of experiments, and found myself walking in every day to my lab where I was conducting a animal behavior experiment on intertidal mollusks, these little tiny snails almost. And I would walk in every day and talk to the snails and, say, how are you doing? And I would laugh and say, oh my gosh, why am I talking to these tiny animals that are never going to be able to talk back, right? And realized that I really, truly wanted to work with people. So somewhat of a, circuitous next few years landed me in North Carolina, where I decided I wanted to become a doctor. And
Did you ever did something with your marine biology degree? Or did you do some marine biology at some point before you went to medical school?
Not really. I mean, I started diving. So during college, studied abroad in New Zealand and Australia, and got my first taste of diving, scuba diving on the Great Barrier Reef in Australia, and loved it. And so that was where I found, that sort of interest, and have continued to dive, but nothing really, scientifically based. I more just do it for fun and not get in the cold water of San Francisco, but only go when it's, tropical on vacation or something. So, but yeah, I got interested in medicine kind of after college, and had to go back to school, and took a pretty long route, many years of exams and more work, and ended up back in medical school. And I actually thought I wanted to be a cardiologist. I love physiology. I love studying pathophysiology, meaning the science behind how diseases happen in the body. And I went to medical school back in Oregon, where I grew up. And found myself in residency in San Francisco, where I currently live and practice. But got quite surprisingly interested in palliative care as a field, but I'm actually a generalist. So I'm trained in internal medicine. I practice hospital medicine at California Pacific Medical Center in San Francisco, and take care of folks when they have to be admitted to the hospital, meaning they're sick enough to need to stay overnight in a hospital setting. And I'm actually not a palliative care doctor. I'm just, I call myself sort of a palliative care activist, because I think it's an amazing field that I want everybody in medicine and outside of medicine to have an understanding about and recognize its importance.
Yeah, for our listener, can you describe to us, like, what is the difference between hospitalist versus palliative care doctor versus other primary care doctor?
Sure. So there are many, obviously, fields of medicine that you can specialize in. The one, that I'm in is called internal medicine, which means I take care of adult patients. And, when you do residency in internal medicine, you can become a primary care doctor and take care of people when they come and see you in the clinic. Or you can become a hospitalist, meaning you specialize just in taking care of people who are admitted to a hospital setting. And those folks typically don't, as a hospitalist, you don't tend to also have a clinic practice. You're either one or the other these days, either staying in the hospital or, seeing patients in a clinic. And palliative medicine is a specialty of medicine that is focused on quality of life for people and their families facing a serious illness, and can be used at any time during the course of illness, ideally at the time of when you're diagnosed with that kind of illness, to help support you along your journey. And it deals with things like, pain control, other symptoms that are bothering you, focuses on things like psychosocial, spiritual distress that sometimes can come along with a life-threatening illness. And it's cool because it's a team-based approach. So it's not just, the doctor who comes and sees you. It's also probably a nurse and a social worker and maybe a chaplain if it's, something that you want. So I love it because it's really thinking holistically about a human being and taking the sort of family context and structure also into account when thinking about illness. So it's a specialty that you actually do a fellowship to be trained in. And I did not do fellowship. I am a generalist, but have plenty of conversations along the lines of kind of palliative care focused with my patients in the hospital by virtue of the fact that they're often older adults and maybe chronically ill or, have just been diagnosed with a serious illness in the hospital. And I sort of feel like, all doctors should be able to have some important conversations with their patients, no matter if you're in a clinic, you're in a hospital, you're, in a cardiologist's office, to talk about, prognosis and the goals of care and what really matters most to you as a patient.
Yeah. So, obviously, this is something that you are interested in after you become the doctor. Is this a standard now for the medical student to have that kind of training? Because at some point they need to have that conversation to encourage the patient to work with somebody in the palliative care area.
Yeah, it is becoming more standard in terms of medical education. I would say that palliative itself is a fairly new field, surprisingly. People have always gotten sick. People always die, right?
Yeah.
But in terms of becoming a specialty, it's only been around since the mid-2000s. And so I would say over the last 5 or so years, there's more standardization of curriculum around training medical students and residents in this area about how to talk to patients. But it's actually an area that we need to do a much job of. So a study came out in 2016 in the Journal of the American Medical Association that surveyed a number of practicing physicians, and 70%, that's 70%, said that they had not been trained in how to have difficult conversations with their patients.
Wow.
That to me, it's shocking, because so much of what we do as physicians is sit down and talk to patients about, any number of things. But the more important things, in my opinion, are, breaking bad news to a patient about a life-limiting illness, or, conveying a difficult prognosis, or talking about what the treatment options are in the face of that information. And if we're not taught how to do that, if it's treated like any other skill that we learn as doctors, I think we're doing our patients and their families a huge disservice. Not to mention it's distressing to us. And, people make decisions that, maybe are going to cause them to suffer, or maybe aren't, in line with what they want, but they're not given all the options, and there isn't a discussion that's had about what's possible based on what they are hoping to have happen. So it's something that actually, thinking a lot about, and trying to make changes on the medical education curriculum side.
This podcast is sponsored by IO Life Science, a Silicon Valley-based medtech design and development consultancy, transforming your technologies into a unique healthcare solution. For more information, visit their website at iolifescience.com. This podcast is also sponsored by Brown Rudnick's Global Life Sciences Group, a team of legal professionals that helps life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownrudnick.com. Yeah, no, I was reading an article last week about doing robots having a conversation with the patient, and the robot was the one who delivered the bad news to the patient. It was a huge. Do you hear about that one?
I did a little bit, yeah, and yeah. I mean, I think no matter what, these are like really hard conversations, and we need to be doing a better job of incentivizing people to be, getting trained to have them, or at least understand how to talk to, patients about things that are hard.
Right.
And together, coming up with a plan that works. And so whether it's coming through, a telemedicine robot, or it's in person, it's a pretty difficult thing to do. And deserves just as much attention as, we're putting on, surgeons who spend years and years training how to operate in the operating room. This also is an incredibly technical skill, and, requires a lot of practice to get it right.
Yeah. I was thinking about, we are in the field of creating technology to try to help treat patients. And sometimes our focus is about how to make the patients get better. And so the same thing with doctors. I think when they go to medical school, they want to treat patients to get better, but sometimes patients don't get better. So it's, we all will die. You first started your interest in cardiologists, and then how do you make that change? What prompted you to make that decision that this is an area that I'm interested in? Because cardiologists tend to go in and then just like, I'm going to go in and fix you.
Right, exactly. It was actually the first few months of my medical internship, and I was in the ICU. Speaking of technology, where we have incredibly advanced technology to save lives, and it's wonderful. I mean, Western medicine has advanced so much in the last half a century, that we really can keep people alive, and we save many, many lives every day because of what we're able to do. What I was struck by actually was the amount of suffering that was taking place for many of these patients, often older adults who were frail and dealing with chronic medical problems, but then also very advanced cancer or advanced heart failure, something that unfortunately despite our advanced technology, we weren't going to be able to cure. And despite that, I think many people were ending up hooked up to tubes and machines in their last moments of life, and hidden away from their families, and in a situation where they were not being engaged in conversation about what mattered to them, and did they understand what was going on, and did they want to continue forward on this path versus something else. And I realized that there was a huge mismatch between what the expectations of some of these patients and their families was actually happening. And I realized that there was just huge gaps in sort of the ability to communicate, and taking time to sit down with patients and families to really talk through some of this. We get very caught up in the day-to-day around the technology and focusing on, minute to minute, well, what's happening, with the sodium level, or what's happening, with the ventilator in this particular, small thing. And we don't take a step back and say, well, what's actually going on, for this patient in the context of their illness and their life and their family. And I'm lucky to have amazing mentors where I trained in palliative care. And these were folks that would come in and talk to patients when they were asked to discuss difficult subjects like, the prognosis or the trajectory of whatever was happening in terms of the illness. And I saw just how important it really is to, know how to have a conversation, a hard conversation with people and their families, and what a difference it can make when you know how to do it, and come up with a plan together. And so I got really interested in the field of palliative care that I had not really been exposed to during medical school. As you said, medicine is focused really on fixing problems, and we aren't really thinking about what the role of a doctor is in healing when cure is not on the table, which unfortunately for a lot of people, that's still the case.
Also, the role of the doctor, sometimes you need to bring the bridge between the patient and the family, because I think what the patients probably want are different from what the family wants. And how do you bring them together?
Sure.
Like, what is that role for the palliative care doctor? How do they kind of have to act as the mediator sometimes?
Sometimes, yeah, that's true. Sometimes what the patient wants and what the family wants are different. And it starts with just sitting down and having a conversation, just opening up a dialogue, which, far too often we're not doing, and conveying, as openly and honestly as possible what's going on. We can't know everything. There's always uncertainty in terms of prognosis, but at least, sharing what we can and saying, here's where we are. Here are the options in front of us. What makes sense to you? How do we go forward and honor your goals and values, life that you've lived, right? And so, again, these are really hard things to dig into, especially when, for me, I'm meeting some of these people for the very first time in the hospital, and really having to build rapport, or try to build rapport very quickly, and talk about some really difficult, complicated, nuanced things.
Yeah. And how do you build that rapport quickly? Because they have to trust you very quickly.
Yeah. Well, I think there's a few things you can do. I mean, sitting down and standing over people, I think is an obvious one, but maybe not intuitive. I think most physicians, are used to the model of wearing your white coat, keeping, a very serious face on, standing in the room, and sort of talking at people. I actually think, we need to be trained in how to, walk into a room and sit down with somebody, look them in the eye and say, hey, introduce yourself. Hey, how are you feeling today? How are things going here? What can I do to help you? So it's, there's all sorts of studies that have been done in terms of how physicians communicate. And most of them show that we don't do a good job. We're in the words that we use, in how we, approach patients. It's, again, it's a hard thing, and we need to be practicing doing it more. We need to be incentivized to be doing it more. Unfortunately, we don't bill in medicine for sitting down and talking to people much. we're sort of incentivized to do things to people, do procedures. So, that's a problem, that incentives are not aligned in that sense.
Do you think it's also the fact that in the society, people tend not to talk about death? And that becomes something that makes everybody feel a conversation that nobody wants to talk about. And as a result of that, people try to avoid it as much as they can, as long as they can. And then when it comes time, everybody kind of not ready to talk about it.
Yeah, I think that's totally true. We're not personally thinking about our own mortality. So therefore, we're not talking about it with the people that we love, and definitely not planning ahead for it often enough. And unfortunately, how that plays out on the medical side of things is far too often people are ending up, getting care that they don't maybe want, and they definitely don't understand. And it's not in line, with their goals and values. And so that's in all of the work that I'm doing, really trying to think through how do we reach people earlier with this message, on a societal level, but also, of course, on the medical side of things. I think that there are so many points in time when it makes sense to take a pause in life and reflect. And whether it's, at the birth of your child, or you're maybe, getting married or partnering in some fashion, to sit and think about, if something were to happen to me, who might speak for me?
Right.
Or if something, were to happen to me, who would take care of my child? Or what might that look like? And I think it really is, of course, an important conversation, and it really behooves all of us to at least spend a few moments, maybe a few times, to sit and talk about this.
Yeah, no, I think it's like, I had a personal experience that I lost my husband almost 6 years ago now. And I learned a lot from the experience. You learn everybody will die eventually. You just don't know when. So it's always good to at least try to do something that you have control over. And then the rest is something that, you can't control. But when do something about something that you can take control of, I think that at least that's a lesson that I learned from it. By avoiding the conversation doesn't mean you're not going to die.
That's right.
This podcast is sponsored by IO Life Science, a Silicon Valley-based medtech design and development consultancy, transforming your technologies into a unique healthcare solution. For more information, visit their website at iolifescience.com. This podcast is also sponsored by Brown Ratnick's Global Life Sciences Group, a team of legal professionals that helps life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownratnick.com. But I thought it was interesting we could talk about the documentary movie that you made. I thought that was I watched it when you did your first Extremis. It kind of introduced to the larger audience about end of life. And if you, for the audience, the listener, if you can tell us about that movie.
Sure. Yeah. Extremis is a short documentary. It's 23 minutes long, filmed at Highland Hospital, actually in Oakland, and really looks at end of life decision making in an ICU setting. So the sickest, folks end up in the ICU, and what are the conversations that take place between those patients and their families, and the clinicians and the families, and then also the clinicians among each other about some of these very difficult ethical, moral dilemmas when people are quite ill and facing the end. So it's actually on Netflix and available. Has been out for a couple of years now, and we were nominated in 2017 for an Academy Award. The film is beautiful. Dan Kraus, our director, just did a phenomenal job. Spent months filming on and off in the ICU, and really wove together a a beautiful film that shows a lot of these really intimate moments in time between these families and patients and doctors, and brings up a lot of questions that I think are really important to consider. And most people, fortunately, right, don't know what it's like to be sick in an ICU. Right. If they haven't personally experienced it or worked in healthcare. And so part of the motivation behind funding that film was really to shine a light in that dark place, to show people, here's what can happen, and here are the things maybe you need to be thinking about and talking about, so that you can, make decisions that are right for you.
Yeah, and I found that with life, it's like an unknown is always scary. When I think if you are more aware, you are more educated, you have more knowledge about what's going to happen, I think it becomes less scary. And I think that movie, at least when I watch it, it kind of gives you that help other people to understand, like, this is what happened, that's what's possible. And I thought that was really moving movie. And so maybe could, for the sake of our listeners, is like, how do you end up, making a movie from, being a doctor and doing this documentary, producing this documentary movie?
Yeah, well, it was kind of serendipitous. I really got interested right after residency in thinking about how to leverage philanthropy to make a shift in terms of how people learn about palliative care, how they are thinking on a personal level about their own mortality, and thinking about, advanced care planning, making some, creating documents, having discussions about care preferences as you age. Mm-hmm. And I am friends with Dr. Jessica Zitter, who is in that film. She's an ICU and palliative care doctor in Oakland, California. And she and I were chatting one day, and she shared, they're filming a documentary in the ICU here. Mm-hmm. I think you might be interested in checking it out. I got connected to the director and was just blown away when I saw a clip unedited of what he had put together. I said, this is a story that needs to be told, and this is a wonderful way to do it through documentary film. Mm-hmm. And so helped to fund that project. And we had no idea that later that year, Netflix would decide that they were going to get in the business of acquiring short documentaries and distributing them. Prior to this, short documentaries had a hard time of being seen by the public outside of a film festival. And so we were the first short that they ever bought. And the film, obviously did quite well. And I think speaks to the fact that it, was incredibly well made, but then also that there's a real appetite for this content, that more and more, I think people are really wanting to engage with this difficult subject, mm-hmm. and they're watching it, and hopefully they're talking about it. So it was really random that as a physician got involved with documentary film, but I just feel really lucky to have been able to be a part of it.
Well, that's interesting. I mean, I learned, like a lot of people, things happen sometimes through serendipity. I thought that was interesting. That happened to you as well with this movie. So you also recently have a second movie, Endgame, that's also getting Oscar nominated. It's also touching on this similar subject. Can you tell us more? How is that different from, the Endwell compared to the Extremis?
Yeah, so the film Endgame, it's available on available on Netflix as well. It's a little longer film, 40 minutes, and follows the work of hospice and palliative care providers in San Francisco at the University of California, San Francisco, and then also Zen Hospice Project, and looks at a few different patient stories, as well as following some of the clinicians, including BJ, who's a palliative care physician and a thought leader in the space, and is different in that some of the other issues around, what hospice is, what palliative care is, what are these conversations that take place for folks when they're transitioning from a more curative approach to a more comfort-based approach to care. Obviously a lot of overlap with some of the themes in Extremis, although, very, very different film, and style wise, it was, shot differently as well. It's been also a fantastic project to be a part of. And we're, screening that film around the country at medical schools, community centers, any institution that will have us. We've been doing a lot of conversations around various topics to really highlight the importance of this issue.
Yeah, no, I think this is good. I think this should be a mandatory watch, because we all at some point might experience that in our life. So bringing the topic, I was talking to somebody talking about, what technology can be developed to help the palliative care. What are the areas that you think that it's still a gap from the technology side to improve the work of the palliative care area?
Yeah, that's a great question. We think of palliative care as this very low tech, but very high touch environment. And I think, in a lot of ways it is. We're not, using a lot of hands-on technology to deliver this kind of care. A lot of it is, conversations and sitting down and talking with people. That said, I would say that, millions of Americans don't have access to hospice and palliative care services because they don't live near a hospital or a place where these services are provided, and know that there's a massive clinician shortage in terms of what the needs are. We know that 10,000 baby boomers turn 65 every day in this country, and so there is a huge need for more people to be trained in some of the fundamentals around hospice and palliative care. So all this to say, the field of telemedicine is actually incredibly important for being able to, at least at this point, to provide access for people in rural areas to some of these services. And so people like Michael Fratkin up in Eureka, California, very far northern California, who are able to, through the use of iPads, and laptops, provide the kind of care that people need in their homes, across, hundreds of miles where thing would be impossible every day, for many of these people. And so I think the field of, the space of telemedicine, it will be blowing up around home-based services in the palliative care arena in the next many years.
Yeah, no, I think that's definitely, we see a lot of trend towards that area. Moving to different subject, and I think last year when I saw your name on the Chronicle that you organized the March for Our Lives, I thought that was like, that's another thing that is working on. I was so surprised. Can you tell us more, like what prompted you to organize the March for Our Lives in San Francisco? We can tell everybody about what is the March for Our Lives a little bit too.
Yeah. So quite tragically, 1 year ago in Parkland, Florida, many, students were killed at Marjorie Stoneman High School due to gun violence. And the students of Parkland basically said, these are high school students. They said, enough. We need to be doing more, to make our schools safer. And I was I was traveling that weekend. I remember when, the Parkland shooting happened, and I was with my husband, and we said, gosh, how did this happen yet again? And aren't these students so amazing that they're standing up and saying, we are not going to rest until things change. We need to do something different and change this conversation. And we were really inspired by these 17-year-olds, like, taking their SATs and saying, we're going to get out there and speak on, the national news about these issues. And so we decided to they announced that the March for Our Lives event, the rally, was going to take place in Washington, D.C., and that there would be events, happening that day around the country. So my husband and I hopped online to see, what was being planned in San Francisco, and we didn't see anything. There'd been nothing sort of planned as of that point, and so we created a Facebook event that was a sort of thought to be a placeholder for something else that would happen in San Francisco that weekend, and it went viral. So it was a private event essentially, and invited a few of our friends, and it basically got shared on Facebook. In 3 days or so, 15,000 people had RSVP'd to attend a rally that really we had no idea what we were doing or how it would all come together. But I decided to take that month off from working at the hospital and just focus on volunteering my time to put together an event with many of the local high school students and other volunteers in the community. People just came out of the woodwork to help with this. It was an incredible, intense 4 weeks of planning and learning how to, deal with the city and Parks and Rec and the health department and the police. And you name it, the entire city really rallied around this event in an amazing way. And we had something like 75,000 people out on March 24th of last year to Civic Center in San Francisco for this rally. And it was all about the students. It was just a phenomenal day. And, unfortunately, a lot of work still needs to be done in this area to make sure that our schools and our public spaces are safer. I personally see this as a public health issue, and doing what I can to sort of stand up for reducing gun violence everywhere. But it was an amazing thing to be a part of. And again, just by chance, I think it sort of came together, and
it kind of fell on your lap because okay, somebody has to do it. I have organized all these 15,000 people is going to come to an event.
Exactly.
Okay. Well, that's really interesting. You see a lot of the gun violence. A lot of the Twitter on our lane, I think that was mobilized by a lot of the doctors too. And I thought that was really interesting. I found that sometimes people don't see the pictures of the violence for good reason. They want to protect the victim. But I thought it was really smart to take a photo of the scene and the doctors when they treat. So then you can see the horror of a gun violence that most people don't see until it happened in your life.
Yeah, it's intense, and I definitely think these stories need to be told. I think it's really important for those of us in medicine to have seen kind of the worst of the worst, and what really happens, at the hands of guns, gun violence in this country. It's appalling, and again, I think it's a public health, epidemic, and we need to stand up for making sure that people are safe in schools and in public spaces. A lot needs to be done.
Yeah, and I think this week there's 3 suicides as a result of the impact of the Parkland shooting. I think 2 of them were students at that high school during the shooting, and then 1 is the father of the victim, but then the other one in Connecticut, the elementary school one.
Yeah, it's just devastating. It's hard to even wrap your head around. It really is. It breaks my heart.
So maybe you should make a documentary movie about that.
Maybe. Yeah. I think that's definitely a worthy story to tell.
Yeah. So that's, I always try to end our talk with asking our guests about what books they're reading. And it's part of it is kind of my selfish way to kind of gather what my next book to read. And so what books that you're reading or you read that you think is very fascinating that you recommend?
Yeah. So right now I'm actually reading Dr. Sunita Puri's new book. Just came out a couple of weeks ago. It's called That Good Night, Life and Medicine in the 11th Hour. And it's a gorgeous book about her life. She's a young physician based in Los Angeles, and she's a palliative care doctor. So telling some of the stories of, how she ended up in this field, talking about her patients and experiences that she had through her medical education that led her to be doing this work. And it's just, it's so beautifully written. And so I highly recommend that book.
Okay. Is it something that you feel like the people who are not in palliative care can relate to?
Definitely. Yeah. She's such an amazing storyteller that, it's completely non-clinical. Mm-hmm. The way that she writes is absolutely for the general public. And, it's sort of similar in style to When Breath Becomes Air, mm-hmm. Kalanithi, or Being Mortal by Atul Gawande. It's, I think this book is going to do amazingly well across the board.
Okay. I should check that out. Well, thank you so much.
Thank you so much.
This is fun.